So to finish off our day, we'll be turning it over to a radiation oncologist and a urologist to answer your most asked questions. Dr. Neil Dwyer, urologist, received his medical degree at Memorial University in Newfoundland and then completed his urology training at Dalhousie in Nova Scotia. After this, he traveled to Iowa City, Iowa, and trained in reconstruction and incontinence. He has been a staff urologist in Moncton, New Brunswick for the past 17 years. His practice is in general urology, and he is the reconstruction urology for New Brunswick and often PEI and Northern Nova Scotia. He's active in most aspects of prostate cancer care, from diagnosis to surgery, management of erectile dysfunction, and stress incontinence. Dr. Juanita Crook is a radiation oncologist at the BC Cancer Agent Cindy Aluwalia Hawkins Center for the Southern Interior, pioneer in the field of brachytherapy research and past chair of the American Brachytherapy Society. Dr. Crook studied biology at the University of Toronto and trained in radiation oncology at Princess Margaret Hospital, followed by a postgrad fellowship in Créteil, France, outside of Paris. Upon returning to Canada, she began working in Ottawa in the first Canadian brachytherapy program. Dr. Crook went on to establish a successful program for prostate brachytherapy at Princess Margaret Hospital before bringing her expertise to the BC Cancer Agency in Kelowna. She continues to focus her time on high-dose brachytherapy for both prostate and breast cancer. Welcome, Dr. Dwyer and Dr. Crook. Sorry.
Okay, well, I'll start off here, and Dr. Dwyer and I are very happy to be able to address some of your questions. We got a lot of questions. Many of them were of too personal or specific in nature to be able to directly answer without more information, but we managed to group them into various categories, which I think will cover a lot of the ground. Concerning how to make the diagnosis of prostate cancer, waiting for treatment, side effects of surgery, side effects of radiation. These were both frequently asked. What about hormone treatment? How do you cope with it? How do you tell if you're cured? So we'll proceed with these now. In terms of diagnosis, you have to keep in mind that the diagnosis of prostate cancer can only be made by biopsy. MRI and other forms of imaging are done for staging, to clarify the local extent of the disease within the prostate and if it has spread. Now, we can be like 99% sure that someone has prostate cancer if they've got an elevated PSA and the digital rectal exam's abnormal, or from what we see from MRI, but we can't know the grade of the cancer, the Gleason score, how aggressive it is, and therefore decide what are going to be the best treatments without a biopsy. So biopsy is not going away. And the CUA has approved MRI prostate as a screening tool for elevated PSA. So you can have your MRI first and then only go on to a biopsy if the MRI suggests that that's important. So we wouldn't be relying just on the PSA level. Next.
Dr. Crook, I think we lost Dr. Dwyer. So
he's muted. No, wait a minute. Where is he? We lost him? Okay,
yeah.
Well, okay, I hope he's okay. I'll carry on. A few people did ask about active surveillance, and Dr. Cox has dealt with that in some detail. And basically what this means is no treatment for now. And we recommend this for men with a favorable risk prostate cancer. That means a Gleason 6 or less, PSA under 10, early stage T1 or T2, which is very unlikely to spread or reduce life expectancy. We can also consider active surveillance for older men if for Gleason 7 cancer, especially if they've got other health problems which may be more significant for that individual. So if the cancer doesn't pose a risk, it's very reasonable to avoid the side effects and risks of treatment. And this is often what patients choose. Next. So how do you watch it? Checkups regularly, digital rectal exam with your urologist, repeat PSAs every 3 to 6 months. We do need repeat biopsies. You can't trust just one biopsy, usually within 18 months. And if that doesn't show anything worse, then every 2 to 4 years. And we are also looking now at MRI to guide biopsies and measure progression of disease in men who are being watched. Next slide. So this is an example of an MRI, and you can see a normal MRI here on the left. This is a normal peripheral zone that is pale white. And here you can see that pale white peripheral zone has a gray blot in it here, circled in blue. And that's the cancer. And this is what multiparametric MRI allows us to do. So we can measure it, we can follow it. And that gives us much more information than just the finger and a PSA. Next. When are you going to get treatment? Sometimes the patient is just sick of waiting and it's their choice. They say, no, I forget it, I can't sleep, go ahead. But if the PSA is going up, growth of cancer on the prostate exam, upgrade on biopsy, or progression on MRI. And Dr. Cox went through these things with you. Next slide. So we'll move on now to radiation. There's various types of radiotherapy. People were very specific, like, why can't you tell me what my particular risk of side effects is? Well, it depends on the type of radiation, it depends on the fractionation, it depends on the structures are contoured, it depends on you, your health, your other health conditions. So there's a lot of things that go into that. So external beam can be given in a standard fractionation, which has been used for decades, which is usually 2 gray per day. Hypofractionation, which means a larger daily dose, but a smaller number of treatments. Or internal radiation, which is also called brachytherapy, which can be either a seed implant, which is the classic type, which has been around for 25 years, or a temporary implant, which is the high dose rate type. I left out stereotactic body radiotherapy by mistake, and this is also a form of external beam radiation, but a much larger daily dose and very few treatments. Next slide. So external beam, almost anyone with prostate cancer can receive external beam, any risk group, any Gleason, any age, any health status. However, brachytherapy, the internal form of radiation, has proven better long-term outcomes than external beam. So brachytherapy is often going to be recommended for men who are in good general health and are able to have it. If they have a higher risk tumor, a more aggressive tumor, we would combine the brachytherapy with external beam radiation. The other big consideration of whether you'll be offered brachytherapy is if it's available in your center. They have to have the expertise. Next slide. That just shows a linear accelerator on the left, and then the kind of dose distribution that you can see. You're not going to see my arrow here because it's not my screen that's being shared, but that blue outline of that shape lining the pelvis, that's the target, that's where the lymph nodes are, and the yellow ball at the top is your bladder. And so having a full bladder when you have your treatment is like having a balloon in your pelvis, which pushes the bowel up out of the way and spares you toxicity in your bowels. So that's why you're always asked to have a full bladder. Next slide. The radiation side effects are going to vary from one individual to another. They cannot be precisely quantified for any individual, even when you know all the details. It's going to depend on the method of delivery, the dose of radiation. I can tell you in general that the VMAT and IMRT types are much better tolerated than the older 3D conformal because they modulate the dose of radiation as it's going through your body to maximize it at the place where we want it to be delivered. Brachytherapy, the internal radiation, is the most conformal. It's also the highest dose. So you're going to get more urinary irritation in the short term than you do with external, but the long-term efficacy is higher. Bowel symptoms during radiation can be helped by a low-fiber diet and psyllium, and this is otherwise known as Metamucil. And this is what your oncologist is going to tell you about in your weekly visits. Next slide. So just to give you some examples of doses and why this is confusing and why we can't just give one simple answer, an LDR seed implant brachytherapy delivers 144 gray in a single treatment, but delivers it very, very slowly over 6 months. The high dose rate brachytherapy is actually a much lower dose. It's generally only 27 gray, not 144, but it's given in 2 treatments, but those treatments only take a few minutes, not over 6 months. So that's why the radiobiologic effect is very, very different. Conventional dose radiation, which I mentioned uses the 2 gray fractions, is generally given over 7.5 weeks with a dose of 78 gray. If you give a slightly higher daily dose, you reduce the dose to 70, but you reduce the number of treatments to 28. So the treatment duration is only 5.5 weeks, or sometimes 60 gray in 20 treatments over 4 weeks. And these are all calculated radiobiologically to have a similar efficacy, but it's a calculation. And stereotactic body radiotherapy is the most confined and adventurous in the external beam realm. And that can sometimes be given in just 5 fractions over 2 weeks. It's not given every day. Usually it's every second day or a couple of times a week. So that's the range. So all radiotherapy is not the same. Next slide. We'll quickly look at the brachytherapy. The seed implant, as I said, is very conformal. We deliver it using transrectal ultrasound. The number of seeds depends on the size of the prostate, anything from 65 up to 120. Next slide. These are placed permanently into the prostate with the patient under anesthetic. For favorable risk, it's very effective, can be used by itself, but most of these people will be watched. Intermediate risk, it can also be used by itself. And high risk, we combine it with external beam radiation plus hormonal treatment. And this is for spatial cooperation, because the brachytherapy can only treat the prostate. If we have to treat the lymph nodes or the seminal vesicles, then we need to combine it with the external. Next slide. And this, as I said, is a one-day procedure, 1 hour under anesthetic. You go home 2 or 3 hours later, you recover quickly. Sexual function, as for surgery, is going to depend on your age and the function at the time of the procedure. There's about a 15% loss in the first year, and then age-related decline will continue as the years go by. But this type of treatment is an excellent long-term cure with undetectable PSAs out to 10 years and beyond. Next slide. HDR is very similar to an LDR procedure, but the radioactivity doesn't stay in your body. We just put in a scaffolding of needles, and a single seed traverses each of these needles in turn, pausing in the required places to deliver the desired radiation dose. And that takes about 20 minutes. So it's given very, very quickly. Next slide. And this just shows the scaffolding of needles through the prostate on the left side of the screen. And then those needles are connected with their own individual transfer tubes to the machine that holds a single radioactive source, which is 10,000 times stronger than the seeds we put in permanently. And that delivers the radiation. Then we disconnect everything, pull out the needles, and you're done. Next slide. Surgery. Over to Dr. Dwyer. I think he's reappeared.
I am here. Can you see me and hear me?
Yes.
Okay, I don't know if I'm on video. I can see you, Juanita, but they can't see me. So I look just like her.
We can see you, Dr. Dwyer. You're good.
Okay. Okay. So first off, I want to apologize. We've been on the phone with our internet supplier a few times today, and they reset it apparently just as I was waiting. And when I was being introduced, I lost all my connections and I had to go to my phone. So I'm holding my phone in my hand right now on cellular data to make this work because my Wi-Fi has come back, but it's too late to get back in. So let's talk about surgery. Can you go back one slide? Nope, that's forward. There we go. So in surgery, there's basically 3 main types. We have the robot, which is on your left. Then we have laparoscopic, which is in the middle. And then we have open, which is on the far right. And lots of differences between them, but they're all small technical things. With respect to outcomes and everything that matters, there's no significant difference. These surgery types have been around each for greater than 10 years. And there's been numerous studies in all types. And the bottom line is that there's no definitive papers that show one is better than another. What is definitive is that the surgeon should do the one that they're best at doing. Otherwise, that's all that really matters. Next slide. So how to prepare. I'm just going through, when I prepared these things, I thought of what questions you guys had asked and looking at that. So a lot of things, how can we prepare for surgery? How can we prepare? One of the big things, and this is a little unfair because when you're being told you have cancer, but bottom line is, as a surgeon, healthier people and people who are fit do better. And the biggest ones there are the same things your family physician hopefully talks to you about, like with respect to diabetes and obesity. Surgery is harder technically and on the person if they're less healthy when they come in. And there's a difference between a perceived level of health and what's actually healthy. Another thing that we recommend and we do routinely at our hospitals, we have all patients trained on pelvic floor exercises with a nurse continence advisor, and they're introduced to what this involves and what to expect. So they have a session with a specialized nurse prior to surgery so they know what they're getting into and what to do when the surgery's over, even with respect to having a catheter and stuff like that. On the last note there, basically, what do you do once you've made the decision? Stay active, stay fit, and get your sleep. These are the key things in preparation for surgery. Next slide. So all forms are equally effective. The one advantage of surgery, if there's an advantage of any option, is the fact that when you do surgery, especially as we're now dealing with higher risk cases a lot, we have the option of adjuvant radiation in higher risk cases, which means the radiation is done immediately after, or salvage radiation at a later time. Some of the details, again, addressing the questions asked, is that even with open surgery, I used open is because most people think of robotic and laparoscopic as a much less invasive surgery, but really the short term is pretty similar to the patients. Even with open surgery, they're generally home within a few days. You'll see American data talking about 1 day, but they have a different way of measuring time. You have a catheter drainage for 10 to 14 days. You have a drain in that makes sure everything heals up for a day or two. And you're basically back to full activity at 6 weeks. Of course, when you're back at 6 weeks, it's not like being 30 and you're out of commission. When you're 60 or 65 and you're injured and out for 6 weeks and then come back, it's going to take a while to get back to full activity, but you're released from restrictions at that point. What can we do in the surgery? Well, the surgery can alter how we do the surgeries based on the pathology, and that's the biopsy pathology and the MRI. If we have an MRI or a pathology that suggests a more aggressive cancer, then we do different things. If it's more tight cancer, well contained, we can do nerve sparing. If it's more aggressive, we can do wide resections. Just waiting for the voice there. We can also do large prostates, or if there's a prior prostate resection, then we can actually do these in surgery without having any major issues. Of course, there's a few extra risks with that. I'm just waiting for the words to go away because I was covering the last of my slide because I'm on a phone. There we go. With respect to open surgery, it's a midline incision. The reason I mentioned this is one of the questions that talked about a parallel incision. All incisions are midline. You add up all the incisions done for laparoscopic, robotic, or open. They're all about the same length. It's just the midline one in open surgeries. They're right through the center. Next slide. Can I have the next slide? There we go. So I'm going to change my view here so I can see better. So let's talk about the complications. The complications can be broken down to 3 major categories. Early complications involve blood transfusions. The risk statistically is about 5 to 8%. It does depend on the center you're in, and it also depends on your preoperative hemoglobin. So someone who comes in a little lower is going to have a higher risk. There is no advantage to directed donations. If you do directed donations, you're more likely to get a transfusion. A risk of infection exists. Everyone gets antibiotics. There's a risk with catheter issues. Major injuries such as nerve injury to major nerves that control leg power or rectal injury is less than 1%. Most of us in our career will see 1 or 2 of these. That's hopefully all you see. Intermediate, meaning in timeline here, we have bladder neck scars. They occur often less than 5% over in the first 3 months. And then long-term, the ones that we're going to talk about more in a second are the ones most people are interested in, erectile dysfunction. The simplest way to think about this is the best determiner of successful erections after surgery is your erection success prior to surgery. There's a natural history at play, and surgery is the ultimate equalizer as to what's going to happen. So whatever we do, we cannot improve where you were. It's always going to be a little worse. So nerve-sparing surgery does offer you some advantages with respect to having increased chances of success with therapy. But if you have an aggressive cancer, if you have a Gleason 8 cancer, if you have a cancer that looks like a T3 on an MRI, which means it's bursting through the pseudocapsule, then these cancers we can't nerve spare because it's The paradigm of surgery is success in the surgery for cancer control, then it's continence, and then it's erections, because these are the things that are going to affect your quality of life the greatest in that order. With respect to incontinence, it's prior bladder issues. These are important. Obesity, again, diabetes, and again, more aggressive cancer means bigger resections. Let's next slide. So looking more specifically at the side effects with respect to continence, if you look at data, and data is great when it applies to a group, and I'm talking like this, but when it's talking to an individual, it's not as effective. So the statistics would show you that 90 to low 90% achieve very happy control within 1 year. But the big thing is it's over a year, so it's a journey, not a race. Everyone in the beginning has incontinence. Sorry about that if that came through. Everyone has incontinence in the beginning. There are things we can do to limit that, and that's pelvic floor exercises. Weight control, again, is a critical thing. There are surgical options. I'm a reconstruction urologist by training, which means that I deal with the complications of surgeries, other people's surgeries and my own. And they have great success rates, and these are surgical interventions. The other thing is to compare yourself with similar aged people. So when people are leaking at 65, you have to think of your 65-year-old friends, not your 30-year-old self, because most men who have not had prostate cancer, 65 to 70, have BPH or enlarged benign prostate. And those men tend to have pre-void urgency or get up at night or some post-void dribbling. So they're not peeing perfect at that age, no matter what. You can't compare yourself to the perfect person. And higher risk surgery or higher risk cancer with scars, so you have a higher chance, of incontinence if you have scars and more aggressive cancer. Looking at erectile dysfunction, basically start the rehab as soon as you can. The rehab is simple. It's pills first, so all the pills that everyone knows about, vacuums, needles. And the bottom line is use them. There is evidence that the longer you go without any use, the more likely you'll form permanent scar, and that's in anything. You'll see improvement for up to 2 years. And I always like to give the story to my patients that you'll see a shift where nothing works, and you go from pills to needles, and then over time they start to have some spontaneous erections. So they go back to pills, and then after that they may see spontaneous erections without pills. But that's not everyone. That's just the perfect outcome. But it's going to be, again, a journey. You can do a penile prosthesis if all fails. They are very successful surgeries. They're answering the question specifically. A dry orgasm is what men will experience, but orgasm is not lost. The nerves for orgasm are very different from the nerves for the penis, and they're not affected by this surgery. They're rarely affected in most physiologic conditions. There's a higher risk of erectile dysfunction with age, because age correlates most strongly with erectile dysfunction and more aggressive cancer. Next slide. So what can you do after? Start pelvic floor training as soon as you can, penile rehabilitation as soon as you can, exercise and stay active, and maintain your healthy weight and lifestyle. Next slide.
Okay.
You want to take this, Juanita?
Yeah, sure. So as you may well be aware, androgens are hormones that promote male characteristics. Testosterone is the main androgen, and prostate cancer cells need androgens to grow. This is what Dr. Cox was referring to. I mean, de novo prostate cancer is androgen sensitive. When it becomes resistant to that, it's called castrate resistant, and that's when you have to branch off into different forms of treatment. So we can, when someone presents with a newly diagnosed prostate cancer, using androgen deprivation to block the production of testosterone starves the prostate cancer. So it's most often used to treat cancer that's spread outside the prostate, if it's recurrent after another treatment, or high-risk cancers, we combine it with radiation in order to get better results. Next slide. Why is it combined? Because multiple large randomized trials involving literally thousands of men in North America and Europe have shown that for advanced or aggressive prostate cancer, when you treat with radiation, you go with a radiation-based approach, the results are better when it's combined with the androgen deprivation. So that means more men are cured, fewer men die of prostate cancer, fewer men have it spread to their bones. I mean, every endpoint you look at is better if you go through this period of androgen deprivation prior to and during your radiation. Next slide. Side effects. This isn't a walk in the park. It's not chemo. You're not going to be sick, but it affects a lot of things. The side effects, hang on a second, sorry. The side effects include hot flashes, weight gain, loss of muscle mass, decreased bone, sorry about that, decreased bone density, erectile dysfunction, thinning of the bones, cardiovascular events, can also affect your mood, your energy level. You have to know about the broad scope of the side effects that you're going to get from this before you go into it, so that you have a game plan on how to address it. Next slide. One thing that I find a lot of men think they're receiving estrogen. No, you are not receiving estrogen. Estrogen was used to treat metastatic prostate cancer way back, 30, 40 years ago, but not anymore. What we do is specifically block your testosterone production. And this is reversible within a few months of stopping those drugs. So what do you need to do? You need to stay active or get active. These are the same thing that Dr. Dwyer was just saying about the surgery. Exercise will preserve your muscle mass and your bone strength. Exercise reduces stress and improves mood. You take vitamins D and calcium to ensure the bone strength is maintained. Exercise helps avoid the weight gain that comes along with androgen deprivation. In order to also prevent the weight gain, a low-fat diet's important. Try to avoid full-fat dairy products. So I usually spend 15, 20 minutes talking to people when they're going to go on this stuff and give them a whole printed list of things they're supposed to do. And if they're listening and they do it, they often come back 3 months later and say, I've never felt better, which is surprising since they no longer have any testosterone, but they've actually done this 20 years ago. They've lost some weight, they're getting more fit, more active, it's improved their mood. So yeah, you can counteract a lot of the side effects of the lack of testosterone. Next slide. Another big question is, am I cured? And I'll deal with the radiation question, and then we'll go back to Dr. Dwyer. So definition of cure after brachytherapy has only recently been established, and that's a PSA less than 0.2 4 years after treatment, or 4 years or more after treatment. And most men after brachytherapy, as they go on to 10 and 15 years, will have a PSA of 0.0 something. After external beam radiation, they don't define cure, at least they haven't tackled that yet, but failure is defined as a PSA that's risen more than 2 points from its lowest reading, 2 nanograms per mil. So how long do you need to be followed with PSA? No matter what you have, whether it's a radiation-based approach or a surgery-based approach, essentially forever. More frequently at the beginning, and generally after 5 years, only annually. And a lot of people, some people ask, well, what can be done? Can I get more radiation if it comes back? The radiation dose is calculated to be the highest possible to achieve cure while respecting the tolerance of adjacent normal tissues and keeping serious side effects under 5%. So radiation generally will not be repeated if it doesn't work the first time. Next slide.
So when we look at surgery, and we look at how we define cure, generally after surgery, because the prostate's missing, you have no PSA. So the PSA should remain undetectable. And I've outlined at the first there part of my slide exactly what Juanita was talking about. We do the similar thing, more intensely follow up in the beginning. Some of it's regarding PSA every 3 months, then every 6 months. And a lot of it's also to do with the dealing with the patient and the implications of the surgery, dealing with the quality of it. So more intense in the beginning. And then as time goes, it's generally a 5-minute visit to look at the PSA. And then most patients are discharged at 5 years back to the primary provider with PSAs for life. The PSA should remain undetectable. There's a lot of different microassays. These are even in where I live in Moncton. I have another hospital down the street. They have a different assay than me. I have another hospital across the border. They have a different one. So the bottom line is when you start to see a rise, we always recheck it. Once we see a couple of rises, whatever the rise is, it's significant in surgery. So that's when we start talking to our radiation colleagues, because if it does start to rise, they may be a candidate depending on the timeline for adjuvant or salvage radiation, which is another chance to actually cure the cancer. Next slide.
So what we've tried to explain here is there's no one answer for everyone. And people will say, some of the questions were directed towards, well, what treatment is going to give me the best quality of life? Well, that's going to depend on what you value most. Is it sex, continence, spending time with grandkids? Do you just want to be alive no matter what the price? It's something you need to discuss with your urologist and radiation oncologist. And the best treatment is going to depend on the characteristics of your cancer, your priorities, and your health. So this is a two-way street, or three-way sometimes, if you've got a multidisciplinary situation where both the urologist and radiation oncologist are involved, and with yourself. So, and the other thing about prostate cancer is you generally have enough time to research your options, think about it, discuss them, and come to a decision. You don't have to decide on the first office visit, well, this is what I want to do, because there's no need to rush that much. Neil, do you have anything else to add there?
No, that was excellent. I missed my beginning, which I was going to make a comment. I hope you emphasize my line that medical students do not do surgery. I hope you said that with some grit, because I put that in. That was a comment that came up a few times. Never happened, never will happen. So that was all I wanted to make sure they knew.
Thanks, Dr. Crook and Dr. Dwyer. And I wanted, you guys had the toughest job trying to answer those questions, and you did a great job dealing with it. So thanks very much. First thing I want to do is, well, first of all, I just want to thank everybody, all the speakers, for their great presentations, and thank all of you for attending. And then I want to just turn it over to Rochelle for just a minute, and she wants to talk about the expo, and then we'll finish things off for the day.